All right, let's get on to Learning Plan 8, antacids and other GI medications. Peptic ulcer disease is an illness that affects either the stomach, which would be gastric ulcer, or the small intestine, which would be a duodenal ulcer. H. pylori is a major causative factor of ulcers, as are NSAIDs, acids, and smoking. Defensive factors that the stomach creates are mucus. It creates bicarbonate to neutralize acid. There's good blood flow, and it creates prostaglandins. So we have 5 types of acid-controlling agents. Let's talk about some of these individually. We're going to start off with antibiotics, though. Antibiotics don't actually control acid. Antibiotics kill H. pylori, which is the causative agent of some ulcers. If you don't kill that bacteria, the ulcer will never fully go away. So the goal here is using antibiotics to kill that bacteria, and then also anti-ulcer or anti-acid medications to reduce the acid levels at the same time. Simple antacids. These medications actually chemically neutralize the acid. They could be aluminum-based, magnesium-based, or calcium-based. They all neutralize acid. They chemically neutralize the acid. There are side effects with every medication. Magnesium commonly will cause diarrhea. In fact, milk of magnesia is magnesium, and that's a laxative. It can also be very dangerous to use in renal failure. Aluminum is excellent for use with renal failure. It also can cause constipation, though. And calcium also causes constipation. The big risk there is kidney stones. So you want to make sure you drink enough liquids to flush the calcium through the kidneys. You can also use simethicone. Simethicone is not an antacid, but simethicone helps release the gas bubbles that could be caught in the stomach, causing stomach pain. Commonly used on babies to help them pass gas and burp. Antacids will bind to other drugs, so you frequently have to take antacids away from, in terms of time, away from other medications. So those are drugs that chemically neutralize the acid. Antibiotics kill the bacteria. What about medications that prevent acid from being produced? H2 receptor antagonists, or H2 blockers, will reduce the amount of acid the stomach produces. We're looking at things like cimetidine, ranitidine, famotidine, tidine. A tidine is an H2 blocker or an H2 antagonist. These are good for GERD, gastroesophageal reflux disease, heartburn, and peptic ulcer disease, both gastric and duodenal ulcers. Take these on an empty stomach, and smoking interferes with these medications. So we need to teach our patients to stop smoking. They can cause an increase in BUN and creatinine, remember that's renal, as well as increased liver function tests, ALT and AST. One of those medications, cimetidine, has a major problem in that it can cause gynecomastia, impotence, and decreased libido. That medication will frequently cause people to stop taking the medication. It is a life-altering side effect. So we would prefer that your patients switch to ranitidine or famotidine. They can cause dizziness, headache, confusion, and disorientation also. Now these reduce some of the acid in the stomach. Proton pump inhibitors reduce all acid. They prevent acid from being produced completely. And we're looking at things like omeprazole, pantoprazole, and lansoprazole. Prazols are proton pump inhibitors. These eliminate all acid from being produced. Now, a couple of special things you need to know about these. Most of these cannot be crushed or chewed. They must be swallowed whole. However, Prevacid comes in a capsule, and if you have problems swallowing, you can open the capsule and spill those little balls, pebbles, tablets, whatever they are, I can't think of the word, but you can put that on top of ice cream or yogurt or whatever the person is able to swallow. Protonix is also special. That's the only one that can be given IV. So that can be given IV, the other ones are all oral. Nexium and Prilosec protonics, they are all enteric coated, which means they dissolve in the intestine. That's why they cannot be chewed or crushed. Let's just quickly compare these medications. Antacids neutralize acid. H2 prevent acid secretion. PPIs prevent acid production. Antacids are as effective as H2 antagonists, but they have more side effect and drug interactions. H2 antagonists are cheaper than PPIs. Do not take these with antacids. PPIs are the most effective for decreasing acid suppression, and you may take these with antacids at the same time. Now we can have some mucosal protectant drugs. Commonly, like one is sucralfate. This is aluminum hydroxide and sucrose. This is a coat. It coats the stomach, it coats the intestine. It creates a physical barrier protecting that ulcer from the acid environment. It doesn't neutralize acid. It doesn't reduce acid secretion or production. It simply exists as a physical barrier. It adds to the normal mucus layer, and it promotes healing. Take these on an empty stomach. They must be taken before you eat. There are no systemic effects of these. They can cause constipation. Now let's talk quickly about antiemetics, anti-nausea, anti-vomiting. There are many categories of antiemetics. Let's look at these in order. The antiemetic, the 5-hydroxytryptamine receptor antagonists, or the serotonin receptor antagonists. We're looking here at ondansetron and granisetron. These relieve nausea and vomiting by blocking the serotonin receptor in the central nervous system. This is the drug of choice for postoperative and chemotherapy and radiation therapy induced nausea. If you're working on a med-surg floor and you have people who've had surgery, you will almost always give them Zofran first. There's very little sedation. There may be extrapyramidal symptoms, but more likely the biggest side effect will be transient elevation of liver enzymes, ALT, AST. Again, this is the best for post-op chemo and radiation. Phenothiazines such as chlorpromazine, prochlorperazine, and promethazine. These block dopamine from receptor sites in the brain. These are very good for nausea and vomiting induced by drugs, radiation therapy, surgery, and opioids. These also can be used for nausea caused by vestibular irritation, such as Meniere's disease. They have antihistamine effects, so you're looking at sedation, cognitive impairment, extrapyramidal reactions, and hypotension, and antihistamine effects. So you're going to have the dry mouth, the tachycardia, constipation. You can use corticosteroids, such as dexamethasone, methylprednisolone. These relieve nausea and vomiting by an unknown cause. They are most effective for chemotherapy-induced nausea and vomiting. Very few side effects in low-dose, short-term therapy. You can use antihistamines. Now these are the best for Meniere's disease, which is vertigo of the inner ear. We're looking at dimenhydrinate, which is Dramamine, hydroxyzine, meclizine. These block the action of acetylcholine and histamine. They're very good. They cause a lot of sedation, though. Blurred vision, constipation, urinary retention. So that's the important side effect of antihistamines. We can use anticholinergics like scopolamine. Scopolamine is commonly used as a transdermal patch, a little button patch that goes right behind the ear. This relieves nausea and vomiting by blocking the action of acetylcholine in the brain. Very good for motion sickness, for long-term continuous motion sickness. The antihistamines are good for short-term motion sickness. You can use cannabinoids. The medication is dronabinol. This is based on cannabis, unknown action. Very good at working with nausea and vomiting induced by chemotherapy. It also stimulates the appetite. And we can use benzodiazepines, diazepam or lorazepam. Remember, azepams, benzodiazepines. These produce relaxation and inhibit the central cortex input to the vomiting center. They decrease anticipatory nausea. If you're taking medication and you always get nauseated by it, just knowing you always get nauseated by it can trigger the nausea. These reduce that anticipation and help just break that mental cycle of nausea. And we can use a prokinetic. A prokinetic increases movement. Pro to increase, kinetic is all about movement. Something here is like metoclopramide. This is very important for increasing the motility of the stomach to help the stomach empty out. So if you have a person that has slow stomach emptying, commonly they'll be given metoclopramide to help the stomach push the food into the intestines for further digestion. We can also talk about an emetic. This is something that causes nausea and vomiting. Ipecac syrup is the most common one. It was used to be encouraged to be kept in all homes in case kids would get into poisons. Now it's very rarely used in the home. Almost always it's used in an ER setting only under the supervision of a poison control center. Let's talk about laxatives. Laxatives are used. Laxatives are drugs that promote evacuation of bowels and defecation. Cathartics are drugs that promote stronger and complete bowel emptying. So cathartics are powerful laxatives. They should not be used in undiagnosed abdominal pain. You don't know what's causing the pain. It could be many things. And so you're not going to give you're not going to give a drug to someone when you don't know what the cause is. So that you need to find out first. X-rays will be the first thing they'll do to look for blockages possibly. There are 5 categories of laxatives. Bulk forming, things like psyllium, methylcellulose, Metamucil, and Citracel. These absorb water, which softens and enlarges the fecal mass to promote peristalsis. When you're giving these, you must give water, a lot of water. They need a lot of water in their gut, in their system, so that it has the water to pull in there. If you don't give them water, if they get dehydrated, you could risk dehydration and a small bowel obstruction. Laxatives, like docosahexaene sodium, these soften the stool by facilitating penetration of the water. It causes secretion of water and electrolytes into the intestine. This is usually used prophylactically to prevent constipation. Now what about stimulants? A cathartic, a stimulant like bisacodyl or castor oil. These irritate the bowel to increase peristalsis. They increase the amount of water and electrolytes within the intestinal illumination, and it stimulates defecation. These are commonly abused. People that use these to have a bowel movement get to the point where they need these to have a bowel movement. We could have an osmotic laxative, like magnesium hydroxide, milk of magnesia, which I mentioned earlier, or a polyethylene glycol, or Golightly, or glycerin suppository. These retain water and soften the feces. Fecal swelling promotes peristalsis. It draws water into the intestinal lumen. And then there's miscellaneous laxatives like mineral oil and lactulose. It lubricates the stool and the colon, or it slows colonic absorption of water from the fecal mass. This is good for fecal impaction. It also eases the process of defecation. All laxatives can cause electrolyte imbalance, so you need to be observing labs for electrolytes such as potassium and sodium, major electrolytes that you need to watch. And then we have antidiarrheals. Diarrhea is abnormally frequent passage of loose stools. Could be acute, could be chronic. Acute is sudden onset lasting 3 days to 2 weeks, and it's usually self-limiting. Commonly it's caused by a virus. It's miserable. You treat symptoms by pushing fluids, and eventually the body will rid itself of that. Chronic diarrhea lasts longer than 3 weeks. This is usually associated with fever, loss of appetite, nausea and vomiting, weight loss, and weakness. This can be especially severe if there's abdominal pain present. Some causes of pain, I mentioned acute, virus, bacteria, drug therapy, lactose intolerance, or protozoal. These are short-term, 3 days to 2 weeks. You'll be unhappy, but it will go away. Chronic could be caused by tumors, diabetes, irritable bowel syndrome, hyperthyroidism, and ulcerative colitis. We'll treat these differently based on the cause. We could use adsorbents such as bismuth, subsilate or Pepto-Bismol, or adipologite kaopectate. These coat the wall of the GI tract. It binds to the causative bacteria or toxin, and it helps your body excrete that. We use this for diarrhea. We could also use an anticholinergic, like a belladonna alkaloid. This decreases intestinal muscle tone and peristalsis of the GI tract. It's also used for diarrhea. We could use intestinal flora modifiers, like L. acidophilus. Florastor is a brand of this. Yogurt with live cultures is the same thing. This supplies missing bacteria to the GI tract and helps suppress the growth of diarrhea, which causes bacteria. Remember we talked about overgrowth of bacteria when you're taking an antibiotic? That's called a superinfection. This is what you use to help treat a superinfection. And we can use an opiate, diphenoxylate or loperamide. These also decrease bowel motility and relieve rectal spasms. It decreases transit time through the bowel, allowing more time for the water and electrolytes to be absorbed. All of these are used for diarrhea. That's it for GI medications. Come back for endocrine system.